Okay, picture this. It's a Tuesday morning, nothing special about it. You're in front of the bathroom mirror, shaving, putting on moisturizer, whatever. You're thinking about your commute, what you're gonna make for dinner. And then your fingers brush against something that wasn't there yesterday. A lump right there in the side of your neck.
It's that universal stomach drop moment, isn't it? I think everyone, no matter their medical knowledge, feels that immediate, that primal spike of adrenaline. It's just the pure what if.
Exactly. The mind just races to the absolute worst case scenario. We've all been there. But today we're gonna push past that initial panic. We're doing a deep dive into what happens next. We've got our hands on a really fascinating piece of source material. It's actually a high-level guide for surgeons. They use it to prepare for their FRCS exam.
Right, which is the Fellowship of the Royal Colleges of Surgeons. So, yeah, we're not looking at a WebMD article here. This is the gold standard for how a consultant surgeon is trained to think when a patient walks in with that exact problem.
And what blew my mind reading this is that it's not just a list of diseases, it's a guide on how to think. It draws this really sharp line between, say, a novice doctor who's basically just filling out a checklist, and an expert who is doing something called surgical sieving.
That's the core concept. Surgical sieving is, well, it's active clinical reasoning. A novice collects data. Do you have pain? Yes. Yeah. How long? 2 weeks. An expert uses every single answer to reshape the probability map in their head. They're constantly ruling things in, ruling things out. It's less like filling out a form and, more like Sherlock Holmes on a cold case.
So let's play Sherlock. To make this really concrete, let's imagine a patient. Let's call him Michael. He's 45, works as a carpenter, and he's found a lump on the right side of his neck. He walks into the clinic. Now, the guide says there is a wrong way to start this whole interaction.
The wrong way is the sort of bureaucratic approach. Name, age, address. So what brings you here? It sounds polite, but medically it's just really inefficient. It lets the patient wander off into all sorts of irrelevant details.
Right, Michael might start talking about a sore knee he had back in 2015 or something.
Exactly. The right way involves something we call risk stratification. And it happens before the patient even really speaks. The surgeon looks at the biodata and immediately starts calculating odds. Take Michael's age, he's 45.
And the guide mentions a specific threshold here, right? The rule of 40.
It's a massive pivot point in head and neck surgery. If a patient is, say, under 20, the statistical likelihood of a neck lump being cancer is very, very low.
Right.
It's usually inflammatory, like a reaction to a cold or congenital, something they were born with. But once you cross 40, the burden of proof it shifts.
So, okay, essentially under 20, you're assuming it's innocent until proven guilty.
Right.
But over 40, it's the complete opposite. You have to assume it's guilty.
Guilty until proven innocent. Precisely. It's not that young people can't get cancer, of course, but the surgeon's internal alarm system is just calibrated to that number. For Michael at 45, that alarm is already ringing.
Then you've got geography and background. I found this part fascinating. It really shows how your past travels with you. The guide specifically mentions where a patient is born.
Geography is destiny in diagnosis, it really is. If Michael were originally from South Asia or Sub-Saharan Africa, the probability of tuberculosis TB being the cause of that neck lump just shoots up, even if he's lived somewhere else for decades.
And if he were from southern China.
Then you have to immediately worry about nasopharyngeal carcinoma. It's a specific cancer behind the nose that is endemic in southern China. It's so common there that a neck lump in a patient from that region is that cancer until you prove it's not.
Okay, and then his job, we said Michael is a carpenter. I mean, I usually think of occupational hazards for a carpenter as like hitting your thumb with a hammer, but the guide flags wood dust as a major carcinogen.
Oh, it's surprisingly dangerous. Hardwood dust, specifically. If you breathe that in for 20, 30 years, it settles in the nasal cavity, it causes this chronic inflammation and, friction, which can eventually lead to a specific type of adenocarcinoma in the sinuses.
Wow. So before Michael has even said hello, the surgeon already knows. He's over 40, he's a woodworker. The risk profile is already building. Now, to cut through all the noise, the source suggests a technique called the one-sentence rule.
I love this tool. You just ask the patient in one single sentence, tell me the main problem.
When I first read that, it felt a little abrupt, almost rude, like you're cutting them off. But I assume there's a good reason for it.
It forces clarity. It absolutely does. Patients are anxious, they want to tell you the whole story, but the surgeon needs the headline. You want Michael to say, I have a painless lump on the right side of my neck, it's been there for 3 months and it's getting bigger.
That one sentence is just packed with data. Location, duration, trajectory, and symptoms.
And that trajectory getting bigger, that's vital. We call it the history of the presenting complaint. But now we have to, get our hands dirty, we have to analyze the lump itself. And for this, surgeons use a mnemonic. Scott MA. Okay, that sounds like a secret society or something. Break it down for us. It stands for site, size, shape, surface, consistency, and fixation. Let's start with site. Where exactly is the lump? Because different lymph nodes drain different parts of the body.
The guide highlighted one specific spot that really freaked me out. The supraclavicular node, that little hollow bit right above your collarbone.
Specifically on the left side, yes. If you find a hard lump there, it has a special name, Virchow's node. In some of the old textbooks, it's called the seat of the devil.
The seat of the devil. That is ominous.
And for good reason. The lymphatic drainage for that specific spot comes all the way from the abdomen, the stomach, the pancreas, the gut. It travels up a tube called the thoracic duct, and it dumps into the veins right there on the left side of the neck.
So a lump in the neck is actually a signal flare from the stomach.
Exactly. The problem is deep in the belly, but the very first sign is in the neck. That's why knowing the anatomy is so crucial. You can't just look at the neck in isolation.
Okay, what about how it feels? Consistency. The guide uses some weird terms like matted. What does a matted lymph node even feel like?
Imagine a bag of marbles. Normal lymph nodes feel like that. They're distinct, individual, you can move them around a bit. You can feel the edges of each one. Now imagine you poured super glue into that bag of marbles and let it set.
They'd all clump together into one big solid mass.
Right, that's matted. It happens because the disease, usually TB or metastatic cancer, has broken through the capsule of the lymph node and fused them all together. If you feel that, you know the disease has breached the containment wall.
Which brings us to fixation. This is checking if the lump moves, right?
Oh, yes. You might ask the patient to tense their neck muscles, where you gently wiggle the lump yourself. If it slides around under the skin, that's better. But if it feels tethered or sort of glued to the muscle underneath,
that's bad news.
It implies invasion. The cancer isn't just in the node anymore, it's anchoring itself into the neck muscles or the carotid sheath. In staging terms, that bumps the patient from a generic N1 straight up to a T3 or T4.
And for those of us who aren't oncologists, T3 or T4 means?
It means it's advanced. It means the surgery just got much harder and the prognosis just got much more serious. It's dug in.
There was one specific question in the source about the lump that I thought was so strange at first. Does it swell up when you eat?
Ah, the mealtime connection. This is pure mechanics. When you sit down to eat or even just smell a pizza, your salivary glands start pumping out saliva to help you digest.
Pavlov's response.
Exactly. But if you have a stone blocking the duct, like a kidney stone, but in your jaw, or a tumor blocking the exit, that saliva has nowhere to go.
Yeah.
The gland swells up, it gets tight and painful right while you're trying to enjoy your dinner. Then, maybe an hour later, the saliva slowly drains out and the swelling goes down again.
So it's just a plumbing issue.
It's a hydraulic pressure issue, yes. That's a great way to put it.
Okay, I want to talk about pain, because this is where my intuition was completely 100% wrong. If I find a lump and it hurts, I panic. If it doesn't hurt, I assume, okay, I'm fine. But the guide says it's the exact opposite.
This is the paradox of pain in head and neck surgery. And it's the hardest thing for patients to grasp. A tender, red, painful lump is usually an infection. Your body is fighting bacteria, there's inflammation, it hurts. That is actually good news.
Because it's probably temporary. It's a battle your body is actively fighting.
Correct. But a hard, rock-solid lump that is completely painless, that is terrifying. Cancer cells often grow very quietly. They evade the immune system. They don't trigger that acute inflammatory pain response until they're massive or invading a nerve.
So it doesn't hurt is not a reassurance.
No. In a 45-year-old like Michael, a painless hard mass is cancer until proven otherwise. It's a potential red flag.
Let's look at some of the physical tests the guide mentions. These sounded like parlor tricks to me, but obviously they have serious value. The Valsalva maneuver.
Right. You ask the patient to pinch their nose and blow, or strain like they're lifting something heavy. This increases the pressure inside your throat and your chest. If the lump suddenly pops out or expands, it tells you it's connected to the airway, like something called a laryngocele, which is an outpouching of the windpipe.
And then there was Pemberton's sign, which sounds like raise your arms until your face turns red.
This one is pretty dramatic. It's used for a retrosternal goiter. That's when the thyroid gland grows downwards into the chest behind your breastbone. The space in your upper chest, the thoracic inlet, is a really tight bony ring. It's crowded.
So if you stick a big thyroid gland in there,
It's like putting a cork in a bottle. When the patient raises their arms, it actually pulls that mass up into that narrow opening. It compresses the big veins that drain blood from your head, so the blood can't get down to the heart, it backs up. The patient's face turns beet red, veins pop out on their forehead, and they might even start wheezing.
that sounds incredibly distressing to see.
It is. We call it facial plethora. And if you see it, you know that mass is big and it's in a very dangerous spot.
Speaking of dangerous spots, let's move on to the danger signs. The source uses the acronym HARD neck. This is where we stop being detectives and start being emergency responders.
These are the signs that the airway or other vital systems are compromised. The most critical one is stridor.
And that's the sound when breathing.
It's a harsh, high-pitched gasping sound. It means the airway is physically narrowed, the tumor is literally crushing the windpipe. That is a drop everything and go to the ER moment.
And voice changes. Hoarseness.
This is a haunting one. The vocal cords are controlled by the recurrent laryngeal nerve. This nerve takes this long, winding path down into the chest and then back up the neck. If a patient comes in with a lump and a hoarse voice, it tells us the cancer has invaded that nerve.
So the voice change is literally the tumor paralyzing the vocal cord.
Yes, it tells us the tumor isn't just sitting there anymore, it's attacking the local infrastructure.
Then there are the B symptoms. These are systemic, right? They affect the whole body.
Yes, often associated with lymphoma or TB. We ask about three things: fever, weight loss, and night sweats. But not just, oh, I felt a bit warm.
The guide was very, very specific about the sweat.
Drenching night sweats. The question is, do you have to get up and change your pajamas or even the sheets? We're talking about a profound physiological reaction. And for weight loss, the threshold is about 10% of your body weight in 6 months without trying.
Which is a lot. That's the cancer basically eating your energy reserves.
Exactly, it's a metabolic parasite.
Now here's the plot twist that I found most compelling in this whole thing. We've been focusing on the lump in the neck, but the source says often the lump isn't the primary problem, it's just the messenger.
This is the concept of the hidden primary. In the vast majority of adult neck lumps, the cancer didn't start in the neck. It started somewhere else, the tongue, the tonsil, the throat, and it spread to the lymph node in the neck. That lump is a metastasis.
So the surgeon has to go on a hunt.
A hunt to find where it came from. And it's a systematic hunt. You check the scalp, maybe there's a small unhealed sore hidden under their hair that's actually a skin cancer draining down. You check the mouth, looking for white patches or ulcers.
The one that surprised me was the ears. Why would you check the ears if the lump is in the neck?
Referred pain. This is a classic gotcha. The nerves that supply sensation to your throat also supply your ear. So a patient might have a tumor deep in the base of their tongue, but their brain interprets that pain signal as coming from the ear.
So they come in complaining of an earache.
But the ear is perfectly healthy, and that is a massive red flag. A normal ear exam in a patient with ear pain, you have to look at the throat.
That is just perceptively trippy. You really have to understand the wiring of the body.
You do. You're looking for the fire, not just the smoke.
Let's talk about the final part of the history taking, the lifestyle audit, or as I like to call it, the Vice Squad. We all know smoking and drinking are bad, but the guide gets very mathematical about it.
It has to. It's not enough to just ask, do you smoke? We need to quantify the damage. We use pack years. Packs per day multiplied by the number of years they smoked. If that number is over 10, the risk for squamous cell carcinoma, which is the main type of head and neck cancer, rises dramatically.
But the real danger seems to be when you combine smoking with alcohol. I read about this synergistic effect. How does that work?
This is the multiplier. Alcohol acts as a solvent. Think about what, paint thinner does. Alcohol dissolves the protective mucus lining of the mouth and throat.
Strips away the armor.
Exactly. So now, the carcinogens from the tobacco smoke, the tar, the toxins, can penetrate much deeper into the tissue because the alcohol has basically opened the door.
So 1 + 1 doesn't equal 2 here.
It equals 20. The risk isn't additive, it's exponential. If you are a heavy smoker and a heavy drinker, your risk is just off the charts compared to someone who only does one.
There's also the shift in who is getting these cancers. We used to think of this as an old man's disease, someone who smoked and drank for 50 years. But the guide brings up HPV.
The human papillomavirus. This has completely changed the landscape of head and neck cancer in the last 20 years. We're seeing a huge rise in cancers of the tonsil and the base of the tongue in younger people in their 40s and 50s who have never smoked a cigarette in their life.
And this is sexually transmitted.
It is. It's the same virus that causes cervical cancer. So asking a patient with a neck lump about their sexual history, number of partners, or oral sex practices is now a mandatory part of the diagnostic workup.
It must be a delicate conversation to have, but scientifically it's vital.
It is. And the prognosis is actually different. The HPV positive cancers tend to respond better to treatment than the smoking related ones. So knowing the cause really changes the plan.
One last historical oddity the guide mentioned, childhood radiation.
This is a tragic legacy. In the 1940s and 50s, before we really knew better, doctors used radiation to treat all sorts of benign things, acne, ringworm, even enlarged tonsils.
They were radiating kids' faces for acne.
It was standard practice. And now, decades later, those patients are showing up with thyroid cancers and sarcomas in the neck. It's a time bomb that was set 50 years ago. So asking about it unlocks a possibility you would never otherwise consider.
We've covered so much ground here. From that moment of panic in the bathroom mirror, to the physics of lymph nodes, to the chemistry of alcohol and smoke. I think the biggest takeaway for me is the difference between hearing and listening.
That's the perfect synthesis of this entire guide. The wrong way here's answers to a checklist. It's passive. The right way, the surgical sieving, is active. It treats history taking as a hypothesis testing process.
You're constantly updating your mental model.
Right. If the patient says hoarse voice, the surgeon thinks nerve invasion. If they say night sweats, the surgeon thinks systemic disease. Every single answer narrows the search.
It really gives you a new appreciation for what's happening in that clinic room. It's not just small talk. It's high-stakes pattern recognition.
And the goal is always to get to the truth as fast as possible. Because in head neck pathology, time is tissue. Catching that painless lump early, realizing that the earache is actually a throat tumor, that is how you save a life.
So, to our listener, the next time a doctor asks you a seemingly random question like, does it hurt when you eat? Realize they aren't just making conversation, they're checking the plumbing.
And maybe, just maybe, check your own neck every once in a while. Know your baseline.
Sound advice. That's it for this deep dive into the detective work of diagnostics. Stay curious, stay healthy, and we'll see you next time.
Take care.